Welcome back to Core Anesthesia. Whether you are a student prepping for tests and boards or a CRNA here to earn CEUs, we are glad you've joined us. For more about us, make sure to check us out on Instagram at Core Anesthesia and online at coreanesthesia.com.
Welcome back to Core Anesthesia. I'm Cole here with Tanner, and today we want to continue and finish our discussion on equipment and technology. This is our third episode doing this topic. If you haven't listened to the first two, we went through different equipment setups, when you would use certain equipment in cases versus others, what happens when you have malfunctioning in equipment, whether that is electrical failure, whether that's you're intubating and your glide scope turns off or the fiber optic scope turns off, whatever that may be. We talked through different scenarios of that and just kind of how to manage all of that process. We also talked about sterilizing, cleaning your equipment, organization, etc. Today, to finish off our discussion on this topic, we want now to move more into the realm of what happens when you're meeting a patient for the first time, you're doing the pre-anesthesia evaluation on them. How do you get an informed consent? What is the legal and correct way to get an informed consent? When do you need to get it from the patient versus somebody else? We're going to be looking at the importance of communication within the OR setting between us and other OR staff members. What are the important things that we need to document? How do we communicate from a successful standpoint to ensure safety to the patient? We're going to be talking about different informatics and media technology in anesthesia. So these are things such as now electronic medical records that have come about in the last few decades. And now a growing number of online anesthesia apps through mobile devices, etc. When is it appropriate to use these? When is it not appropriate to use these? How do we use them in the right way? And then we're also going to be talking about how we take different data and risk management results that have come up through studies and how do we bring that into our practice? How do we take standards and guidelines and protocols into our practice to manage our patient care? So that's kind of the outline about where we're going to be finishing today with this three-part discussion. So hopefully you can stay with us. We're going to make this as informative and lively as possible. And again, hopefully it's beneficial to everybody. And the goal of this is just to take this information to provide more safe and successful anesthetics to patients.
The first thing we're going to talk about is the informed consent. And before that, your preoperative assessment and evaluation, what all should be included in that, and really the reasoning for that. So prior to every anesthetic, we are required to perform a pre-anesthesia evaluation and assessment. Many times this pulls in other specialties as you are getting clearances for the patient. Say you have a patient who has an extensive cardiac history, you will have pulled in cardiology to have clearances and recommendations from their standpoint. If it's a patient that has, a significant pulmonary history, then you'll see the same thing from a pulmonologist that is going to give recommendations and clearances with some risks and risk stratifications from their standpoint. But regardless of those clearances, the day of surgery, it's still incumbent upon us to talk to the patient, to do a full evaluation, and then based on that evaluation to create your anesthetic plan that is tailored specifically to that patient. The last thing that we'll do in that pre-anesthetic visit is to get informed consent, and we'll talk specifically about what's all included and what's all needed to get informed consent here. But again, that's going to be different from the surgical consent. That's going to be the actual anesthesia consent that we will get from the patient. Ideally, you're going to be working with maybe a pre-anesthesia clinic, a PAT clinic, or other groups that will be seeing these patients before surgery, which would allow them to receive the instructions prior to the day of surgery, which would be instructions on what medications to hold, how long they should be NPO, what the plan is afterwards as far as are they going to stay into the hospital? Are they going to be going home? Where do they need to, contact their physician for post-op orders? What pharmacy are they going to be used? All those things will hopefully be included with these, pre-anesthesia clinics. Again, it's not always the case that they'll have gone through that. So many times it's important that we have these conversations before the surgery so that you can, one, clarify if they have any questions about any of those things, but then two, just making sure that all of those things are accounted for I had a case the other day where the patient came in thinking that it was just going to be a local procedure, and so they weren't NPO the morning leading up to the procedure. So again, that was just a miscommunication from scheduling and from the surgeon's office with that patient. And perhaps they just misunderstood what that all meant. But it was incumbent upon me when I went and talked to the patient and had my pre-op evaluation that, it's just part of your eval. You ask what NPO times. And that led to understanding that they had eaten that morning. And then, after some more investigation, it was just a miscommunication about what they were expecting to have happen that day. So again, this is hopefully a multi-team approach where you're preparing the patient for surgery. But the point we wanted to drive home here is that this pre-anesthetic evaluation is extremely important to, one, make sure that they stay safe during the procedure so that you are tailoring your plan specifically to their needs. And then also you're getting the informed consent for the procedure on that day.
So on the day of a procedure, the main goal of coming in and doing this pre-op assessment is to get this full history and physical from the patient. You're going to be going through different body systems, reviewing their chart, checking if they've had any previous anesthesia history, any complications from previous history of anesthetics, what surgical history they've been through, any applicable lab work, allergies, what medications they're on. You really want to take this time to do a full review of the whole patient and their body systems, et cetera. You really want to make sure that this patient is medically fit and appropriate for anesthesia and the procedure. There's been several times where I've had to cancel a case in pre-op because the surgical procedure is not a medical emergency, but they are medically not stable enough to undergo the anesthetic to warrant it being an emergent procedure. And so the patient has had to then go get their medical issues resolved and become a more stable state before they can undergo the anesthetic and get this procedure done. So your main goal here is to make sure that the patient is safe and appropriate for this anesthetic. And if they're not, you need to weigh the risk and benefits with what surgery they're getting done, discuss that with the surgeon to determine if this is an emergent level of a procedure or not to move forward with. So based on that evaluation, we rank these patients with a ASA score. And what this ASA score does is it ranges from 1 to 6 and gives a scoring as to how healthy and medically stable the patient is to undergo anesthesia. And so starting with a 1, this is just going to be a normal, healthy patient. And there are a lot of details before I move on that go into all these categories. And I'm not going to go into all those details, but as an overarching definition, a 1 is a normal, healthy patient. A 2 is a patient that has some mild systemic disease, but they're controlled. 3 is a patient that has severe systemic diseases or several of these systemic diseases. A 4 is a patient that has severe systemic disease that is a constant threat to their life. A 5 is a patient who is not expected to survive without the operation. And then a 6 is a patient that is a declared brain dead patient. So maybe you're doing a organ harvest on this patient. That would be an example of a 6. And then there can always be an E behind any of these numbers. And an E stands for emergency. So if you have a patient that comes in, they are an otherwise medically healthy patient, but they were in a motor vehicle accident and you're undergoing surgery, you're going to deem them an emergent patient, but they may be an ASA 1 or 2. They may be healthy, but you're still going to consider them an emergency. Or you have somebody who is at a very medically unstable state. It's an emergency that we get them back there, and they might be a 4 on their ASA. So just because you have an E behind their category doesn't mean they're more unstable from a medical standpoint to begin with. And so you look at their medical history and what all their disease processes are first, and then you put that E behind there if it is an emergent case.
To finish up your preoperative assessment, a couple more things that should be included is obviously when we are evaluating the patient, one of the most important things that we think of as anesthesia providers is evaluating the airway. We go into much more detail on this in our airway module, but just quickly, some things that we will want to evaluate is 1, the Mallampati score, the incisor length, the level of your overbite, thyromental distance. You look at the neck thickness and length, range of motion of the head and neck to see if there's any, cervical instability or if they've had previous surgeries that would limit the amount of head mobility. These are things that we would all check there in the preoperative assessment that is necessary that we do on the day of surgery. I mentioned this previously, but again, we want to just make sure that if they have any clearances from other departments, that we make sure and read through those and take into account their suggestions and their advice, also their risk stratification. This is very important when you think about doing elective surgeries and weighing the risk versus benefit of these procedures. And so it's important that you bring in the experts in those different fields to also bring in their consults and their clearances. So, this can be from cardiology, this can be from pulmonology, you can have renal, neurology, whatever it may be. Look at the patient, look at specific concerns you might have from their history, and then identify those clearances from different departments so that you can effectively manage the patient. Many times this will have suggestions for when they should hold certain medications, or possibly, again, just the risk stratification is very helpful so that you can have that conversation with the surgeon so that you can look at the risk versus benefit of the specific procedure. Lastly, I know we already talked about this, but you need to verify NPO status. This is something that oftentimes we get in a hurry, and it seems like we just assume the patient has been NPO for a certain amount of time. This is obviously something that is so important, something that needs to be part of every preoperative assessment. It's the first question that I ask when I start my preoperative assessment, because honestly, if that is not addressed, then the rest of it doesn't matter. This is what's going to determine, first and foremost, if you're going to be going back to surgery for an elective procedure, verifying that the patient has been NPO for an appropriate amount of time. After you do that full assessment and you verify, your different clearances, you verify your assessment of the airway, you talk to the patient. The next thing that we need to make sure that we have included is informed consent. Informed consent must be obtained for all non-emergency procedures. Again, like I mentioned earlier, this is going to be different from the surgical consent forms. So we are responsible for having the anesthesia informed consent form signed and making sure that the patient is aware of all the risks and benefits of the anesthetic. At a minimum, we need to explain this in a way that, the typical layperson can understand. Anesthesia seems like this really big, scary, ambiguous term, and people are oftentimes not sure of what it's going to entail. Or you can have the flip side of it, where they've had plenty of procedures and they know exactly what they've had with anesthesia and exactly what's worked for them. Regardless, it's still imperative that we are communicating to them in a way that they understand exactly what's going on, making sure that they understand that the anesthetic is going to be either a general anesthesia or it's going to be a MAC, what all is involved with those different types. If we're going to be doing a spinal anesthetic with maybe a little bit of light sedation, all of those things are important that we explain in a way that the average layperson can understand exactly what that means, and also what they can expect with the different types of anesthesia. So we really need to manage their expectations here and make sure they are clear and on the same page when we're talking about the anesthetic plan. This is all important for them to understand so that they can sign this informed consent, so they really understand what we are planning to do for that day for that procedure. It's also important that we disclose alternatives, other ways that we can do the anesthesia, and then the risks and benefits as well. It's never our job to convince them of one anesthetic plan versus another. It's our job to explain the different options and explain the risks and benefits of each of those options and help them clearly understand, the positives or the negatives of those things that are associated with them. I think oftentimes when you talk about a spinal, for example, with a patient, I say, okay, we're going to be doing, a total knee today, and my plan comes in 3 parts. So the first part is a spinal anesthetic. What that means is we're going to do a small injection in the lower part of your back. It's going to keep you numb from about the waist down for several hours. And oftentimes it's when I'm explaining the spinal anesthetic, you can see on the patient's face, or maybe they even verbalize it to you, that spinal anesthetic sounds so scary, or it sounds like this is really traumatic. Why do I need to have something done with my spine when I am having my knee replaced? And again, this is where the burden is on us as the anesthesia providers to explain very clearly in a very understandable way what that is going to do for them, the benefits that is going to do for them. And also, obviously, we'll go into the risks as well. With you could have a subdural hematoma, you could have a risk for bleeding there, you could have anytime we're putting a needle into the body, risk for infection. All these things that we'll talk about. But it's important that you manage expectations and that you clearly explain these different things, because to the layperson, oftentimes they sound very scary or just very ambiguous. And in order to obtain that consent, you need to have that explained to them in a way that is understandable.
Right. And I feel like a lot of the times, especially if I'm going to be doing a MAC anesthetic, I like to get the expectation across as to how that anesthesia is different than a general anesthetic. I can't tell you how many times I have had a patient come in, especially for a GI procedure, and they've told me they woke up in the middle last time, or they've heard stories about somebody waking up, the anesthesia doesn't work on them, and there's this false sense of the patient has the idea that they will be completely out for the entirety of their procedure, even though they're having a MAC anesthetic. And really, according to the standards of care, amnesia is only insured under a general anesthetic. And I always then just like to verify with the patient and explain the expectations that the reason we're doing a MAC anesthetic is because you don't need to be completely asleep for this. We don't want you to stop breathing on your own. We're going to have you comfortable. We're going to have you relaxed. I'm going to have you sleepy. But there may be some times where you have some vivid memories or almost dreamlike memories of being back in the procedure room. You might remember kind of waking up a little bit, going back to sleep, and that's part of this anesthetic. I'm going to keep you comfortable, but we want to keep you safe and allow you to keep breathing through this and explain that expectation. But a lot of times I feel like with a MAC anesthetic, the patients still have this idea that they will have complete amnesia through the whole entire thing, and that really is not a standard of care for a MAC anesthetic, only a general anesthetic. Now, in terms of who should sign the consent, this is really important when you're explaining everything to the patient or the family that is with the patient. So the person that is signing the consent needs to demonstrate, first of all, understanding of the information. They need to show that everything that you explained was understood in an appropriate way. And then that consent can be signed by the patient as long as they are deemed competent and have a decision-making capacity, unless one of the following applies. So if the patient is incapacitated, then a legal decision maker is going to be responsible to sign the consent. If the patient is a minor, then a guardian will be responsible, unless that minor has been emancipated by the court or by a court order, has been married or is married, is pregnant, is a high school graduate, is living independently from their parents, if they're in active military service, or if they're in an active military service, or if they're seeking a specific type of treatment regarding anything with pregnancy, mental health, or drug and alcohol abuse. That's just some to name a few, but there are different exceptions there where a minor is able to sign their consent. And then you do not need an informed consent if it is deemed a true emergency. So you have a patient that comes in from, let's say they're unconscious from a motor vehicle accident, and you are unable to have them sign their consent. You don't have any family members around. You don't need a consent there to continue on. It's deemed an emergency.
The next thing that we want to talk about is communication and proper documentation. When it comes to successful management of a patient, we understand that this is not going to just be a solo show. This is a collaboration between many different people that are going to be taking care of the patient. Communication between all staff members is very important. We have to really focus on closed loop communication to make sure that tasks are being passed along appropriately. So when that comes to intraoperative communication, when the surgeon is asking for heparin, for example, we can now say, when they say we would like 5,000 units of heparin, we repeat 5,000 units of heparin going in now. And that closed loop communication really helps to cut down on errors and improves the care that we give for the patient when we are taking that extra step to close the loop with that communication. Part of the communication that is really imperative for every case is the timeout. Timeout is a time that we stop. Everybody stops what they're doing, takes a moment to verify that we have the correct patient, we have the correct procedure, We are all in agreement about the procedure that is being done. And this is a moment where we stop all distractions and we take a moment to clearly communicate and make sure that we're all on the same page. So the anesthesia role during the timeout varies from facility to facility regarding what is going to be communicated specifically by anesthesia. Many times there is a checklist on the OR wall where we can go through that checklist and make sure that everybody has communicated appropriately and that we're all on the same page as far as the procedure and the patient and so forth. But again, at a minimum, we must be present and we must be engaged during a timeout. I can't tell you the number of times that the timeout is happening and the anesthesia provider is mixing up antibiotics or is finishing one last thing they need to do on their charting. This is a time that, again, we stop, we are engaged, and we listen and communicate effectively during that timeout. And this is really, really crucial for patient safety. This is also where we can express any concerns that we have for the operation or specifically for that patient. This is also where we express any concerns that we have for that procedure or for that specific patient. Say, for instance, we have an issue with low hemoglobin and we're going into an extensive orthopedic surgery. This is something that we will communicate that the patient has hemoglobin of this. We're going to be watching for any bleeding. We need to all make sure that we're on the same page of watching for any bleeding. We'll be watching here at the head of the bed, but also if you seem to get anything, please let us know very quickly. This is a concern that we have for this case. That's just one example of the many different things that you could bring up during a timeout, but it's just important that we take that moment to express our concerns and make sure that everyone else is included on those concerns so they can help us identify them and treat them and manage them quickly.
So then during a case, what are the things that we really need to make sure that we're documenting any type of communication that happens? And while there's going to be a comprehensive list of required documentation you need during any perioperative anesthetic environment, all the way from your pre-anesthesia assessment, all the way to intraoperative interventions, medications, events or procedures such as intubations, art lines, all the way to your postoperative note. There are other things that we need to be documenting specifically in terms of the communication that goes on. And so one of these is going to be events such as timeout. So as Tanner just talked about the importance of a timeout, there is, at least at my facility, we have a certain tab that we push when a timeout has been done, that everything was discussed, everybody agreed appropriately, and we're able to move forward with the event. And so that's something where when that communication occurs, we need to mark that in our system. Another thing that you need to document for communication purposes is anytime I have a medication verbal order per the surgeon. So as Tanner mentioned earlier, if the surgeon says, give 5,000 units of heparin, I have that closed feedback loop communication. I say, giving 5,000 units of heparin now. I go to chart my medication in either my paper charting or my electronic charting method, and I will say, I gave this 5,000 units of heparin, but this was per doctor so-and-so, basically given the understanding that there wasn't a medical reason that I necessarily needed to give this per my anesthetic, but this was given based on the order from the surgeon. So I will always document when that type of situation arises. And then I also document any type of communication from any anesthetic concerns. So let's say I am looking throughout the procedure and I am adding up my blood loss and I notice I've reached a certain amount that is my critical level where I would be more concerned. Then I will document that I have brought that to the surgeon's awareness and attention. We've had the discussion on if we need to give a unit of blood, if blood is already in the room, or if we made the discussion to call blood bank and have them send any blood that's on hold. Any type of vital trends that are going in a direction that I think I need to make the surgeon aware of. If I make the surgeon aware of that, and if I have a communication with them, then I will document that in the chart. Things such as tourniquet times, etc. These are just things that if I have any type of communication with the surgeon regarding my interventions, I will document that. And then lastly, really, you should also be documenting the handoff as well. So when you give report to another anesthesia provider, or typically when we give report to the nursing staff in the PACU or any type of postoperative setting that you're going back to, you need to document a handoff report has been given and that any issues or things that you are concerned about has been provided to them. So these are things that, while there are obviously, I'm not going to go into all the details of documents, things that we need to document throughout the case. Really, these are things that are communication driven. So anytime I have an interaction with the surgeon during a case regarding anything that I'm going to do differently with my anesthetic plan or anything that I see out of the ordinary, I will then make a special note that is documented that I had a conversation with the surgeon so that it is known that I was aware of it, the surgeon was aware of it, and we made an appropriate plan because of that.
Next thing today that we want to talk about is information management systems. So at the turn of the century, the Anesthesia Patient Safety Foundation stated that they endorsed the information management systems to be used in both automated record keeping during the perioperative period, as well as a means to retrieve and analyze data to improve patient care. So from that point on, there's been just a huge growth of the use of these information management systems in anesthesia. We think immediately of electronic charting. This has been something that you may still see, different sites that are using paper charting. There's several sites that I've worked at that have paper charting still going on, but for the most part, this has changed over to electronic charting, especially for the charting of the vitals and things during the actual anesthetic cases. We also have use of the EMR, or the electronic health records, that are used to be able to pull patients' information from even different hospitals, which is really, really nice. This patient doesn't always seek treatment at the same facility. So these have made huge leaps and bounds as far as giving us access to a lot of different records, getting, previous visits, ER visits, previous visits with their primary care physicians, to be able to see different medications they're taking, different problems they've been seeing their primary care for, or they're going to seek treatment for different, disease processes. We can pull a lot of these charts oftentimes through just one EHR, which has been so helpful as you try to make your anesthetic plan appropriate for these patients, just having a wealth of information to be able to dig through. The downside of that is oftentimes it is a lot of information that you need to work through. And so oftentimes I feel like you can go through quickly and it's easy to miss certain things just because there is so many documents oftentimes associated with each patient. But it really is such a nice tool that we have to effectively care for our patients. Many of these electronic health records are very smart as well by giving us clues or giving us specific helps to flag certain parts of the patient's chart. So oftentimes, even when you're writing orders, it will flag with potential medication allergies if they have a drug interaction that also would not be an appropriate reason for you to order that medication. Or if there's altered lab values, oftentimes there's certain flags that will pop up there as well. So there's many different advantages to these electronic health records, even just past being able to pull all these different records, tools that are helpful for us as we are looking over a patient's chart to really draw our attention to certain things that might be more impactful for our care for the patient, or just things that we should pay attention to. And so this has just been very, very helpful. There are protocols at different facilities on how we can use these electronic systems to aid anesthesia providers. One of the things that I want to bring up here that has been, commonly talked about with the use of these electronic health records is the risk for us not paying as close of attention to a patient. And what I mean by that is when we are turned around, possibly looking at the computer instead of having ourselves face towards the patient. Many times our anesthesia machines now, the computers are functionally positioned in a way that we can both be looking through the chart and charting while also having eyes directly onto the patient. Previously, when we just used paper charting, we were able to have that right there next to the patient, and we were able to just keep everything in our view while we were charting. We could be right there with the patient. So this is one of the potential downfalls or risks with the electronic charting. While it is nice that you're not manually putting in the actual vitals every single time, if we're doing something with documentation, oftentimes the concern is that can draw your attention away from the patient. So just a good reminder here that as we talk about all the benefits that are included with them, that we also just pay attention to the potential downside of having the EHR as well. Another nice thing that these electronic health records allow us to do is to help us to provide accurate billing. Many times, because of our documentation in the perioperative sessions or the perioperative period, these systems also will help us to obtain reimbursement and help us as we are working through billing so that they can code correctly and also just make that process streamlined, which is another nice feature of this. Lastly, what I wanted to mention, and this circles back to what I said about making sure that we are vigilant and paying attention and watching the patient, and we're not having our field of vision drawn away from the patient by working on these electronic health records. The nice thing, like I said, is that it will provide those automatic vitals over to your electronic health record, which is nice because it is going to record automatically for you. But it's also important that we are making sure when we're checking out our machines that everything is going to have the alarm set appropriately. Many times, because we would not be physically writing down the vitals, you could lure yourself to sleep, so to speak, and not paying attention to trends. Or if you don't have your alarm set specifically to, what they should be, then these are just going to be recorded onto your computer. And then possibly you could be missing very important trends or things that are going on with your patient's vitals. So again, apart from just the risk for drawing our field of vision away from the patient, also be mindful of your alarm settings and just making sure that you don't have those set to a spot where, since it's all automatically being transferred over, that you're not paying attention or catching on to specific trends that might be important for your patient.
So now let's start talking about informatics and media technology and how do we utilize these in our day-to-day practice. And with the growing number and the growing use of informatics and medical technology and media technology, it's important to discuss in what ways can we use this on a day-to-day process? What days or what time periods should we not be utilizing these things? And specifically what we're referring to is the growing use of either mobile or online applications known as apps that have impacted the way anesthetists practice. And most likely, if you're listening to this very content, you're either going to be utilizing our app that has this information through it, or you're going to be using some other app, or maybe you're on our website online listening to this talk. And so you're already utilizing online media sources to grow your anesthetic knowledge. And in addition to us, there are numerous amounts of mobile apps and other online resources that are being provided to supply more anesthesia knowledge and helpful tools that assist in our day-to-day practice. But it's important to ensure that with the growing number of apps that there are available and resources there are available, it's very important that you're going to be utilizing and choosing these resources that provide evidence-based practice. So the reliability and the quality needs to remain at the top of your list when you're selecting these resources. So under the US FDA guidelines, only apps that have a direct influence on patient treatment are regulated and have peer-reviewed data. So a lot of these sources are not peer-reviewed or regulated in any way. And so anything can be said on them. And it's just important that you take what is being presented from these resources and make sure that it's backed up by evidence-based practice. And that's why specifically we try to list all of our sources under the show notes so that if you have any questions on the material that we're presenting, you're able to go look at the evidence-based practices behind that. But again, it's very important that you're not just picking any tools that you see available to you from an online or media standpoint, but you're making sure that it is reliable. So now with the growing number of these different anesthesia apps, there's a variety of different uses for them. One of the main ones that we see are medical calculators. So that's going to be used to assist with calculating clinical results, drug calculations, anything that you'd be utilizing a calculator for in the health industry. There are also drug reference applications or apps, and these are going to be used for, when should we be indicated to use certain drugs? When are there contraindications to using these drugs? When are there side effects? What are the things that we should be watching out for, etc.? There are journal apps, and these provide medical, scientific research updates, any type of articles being released, etc. And then you have informative or educational apps. So these convert textbook related information into an easy to use mobile version. So this is what our app in essence does. It takes information that has been written down in lots of textbooks, articles, etc., and we condense them in a way that make it easier for people to access. So these can be helpful. These different apps can be very helpful by day-to-day anesthetist practice when confronted with any unique comorbidities or situations that come up. Maybe you haven't taken care of a patient that has this unique scenario or situation, and you want some background information very quickly as to how you should alter your anesthetic plan or anesthetic care. And maybe you are just finishing a previous case, you're getting ready to set up for this next case, and whoever did the pre-op assessment, whether it's you, a colleague, etc., noticed that there's going to be this unique situation. There's going to be a time crunched way in which you want to access this information. And that's why these mobile apps are very helpful in this scenario, because we have a lot of information at our disposal that we can research what's the best way to alter our anesthetic plan. So in essence, a lot of data has been shown that when healthcare related applications have been used in a day-to-day setting, they've really reduced the stress level of anesthesia providers, both during cases as well as having to plan for different patient comorbidities in which the anesthesia provider may be uncomfortable taking care of this patient to begin with. They then are able to reassure themselves by accessing this information quickly, reduce their stress level, and know that they're providing evidence-based care to this patient with this unique situation. There also has been shown that any of these apps that have cognitive aids are really good to assist with following protocols in high-pressured situations. Even in code scenarios, if you have any type of critical events that come up with anesthetic, even the rest of the hospital, these unique situations and high-stress situations that arise, apps that have cognitive aids that walk you through the step-by-step protocols are right there at everybody's fingertips. They're able to utilize them quickly, and it reduces that stress level and actually provides better evidence-based care because they're able to follow through those step-by-step protocols. So after talking through all the positive components of using smartphone applications, using apps on our mobile devices to be able to assist medical professionals through those different crisis situations, including helping patient safety, et cetera, there's also the risk of decreasing the vigilance that we have in the OR by utilizing these mobile devices. And the AANA came out with a mobile information technology position statement, which says certified registered nurse anesthetists have an ethical responsibility to provide safe patient care by avoiding non-essential distractions while caring for a patient. Non-essential distractions, especially those associated with the use of mobile information technology, may lead to significant patient safety lapses, end quote. And so the AANA is basically saying here that while we do have all of these positive components to using these mobile devices with specific apps that we can use on them to improve patient safety, to improve our knowledge just at our fingertips by having these devices, we need to be smart in the way that we manage ourselves and when we use these devices. And if we're using it simply for non-productive uses during a patient care setting, that is going to decrease the vigilance that we have and potentially lead to more medical errors. So if we're going to be using different devices during our anesthetic, we need to be making sure that we're using them to aid in taking better care of the patient, improving patient safety. We're using the right applications on these devices and not using applications on these devices that are going to decrease our vigilance for the patient.
When we talked about using the electronic health record, one of the things that we brought up was just making sure that we're using it in an appropriate way and it is not going to detract from our care for the patient. So to recap, if we're not paying attention to the patient because we're turned around looking at the computer, or perhaps we don't have our vitals alarm set at appropriate monitoring so that we're missing trends or those types of things are happening without us paying attention to it. In the same way, we need to make sure that we're using these apps in a way that is appropriate. There's nothing that is going to substitute your clinical judgment. There's nothing that's going to substitute you being there with the patient and taking care of them. And it's important that we're not relying on these apps to, be the A to Z answer for us as we're caring for a patient. Obviously, in order to use them appropriately, you're going to have your own knowledge base that this is going to be something that is going to be helpful to you, but you also need to make sure that we are continuing to educate ourselves and making sure that we're staying up to date on quality assurance data and, keeping track of those types of things so that we can use them effectively. Again, it's going to be a tool that we can use, but it should never be the end all be all for us as we're managing these patients. Also, the other risk there is anytime you open your phone, you're using your app. If you're anything like me, you can be easily distracted and you open your phone for one thing and you move on to the next thing pretty quickly. And all of a sudden you've spent 10 minutes on your phone before you realize what you're actually doing. And so this is, another potential risk for using these apps, especially in a case or when you're managing a patient. While it can be very helpful and you can use the different calculators and things to effectively manage your patient, it also could be easily turned into a distraction and something that takes away from patient care. So while we wanted to touch base here on some of the really important and really beneficial side of the app use, we also wanted to also just mention quickly some of the downfalls and some of the risks that we should be aware of so that we are using them appropriately. The last thing that we want to talk about here as we wrap up this discussion is quality assurance data and risk management resources. This is going to be another tool that we can use to take good care of our patients. As we understand the, many different technologies that are coming out, many different equipments that are coming out, it's important that we also are understanding how those are working in the anesthesia field. As a new device comes out, it's important that we are paying attention to quality assurance data to make sure it's actually effective. We're also paying attention to risk management reports to see if there have been any issues with any of these things that have come out, and making sure that we are really aligning ourselves with best practices. The ANA and the ASA have published guidelines on the standards of care that should shape the way that we provide care for our patients. And they also publish up-to-date information for risk management that we can use to increase the safety of our patients as well. So it's important that we're paying attention to these things, understanding the, closed claim analysis of various topics so that we can pay attention to any issues that have come up from, whether it's a difficult airway or positioning injuries or whatever it may be, that we are paying attention to the data that is available to us. Again, there's many different resources online, but specifically the ANA and ASA have these guidelines that are so helpful for us as we pay attention to the quality assurance data and then also understanding the risk management resources. Use these as a tool. Use these as a tool that will shape your practice as you read through these different things and understand that there are issues in our anesthetic care. There are issues that come up in anesthesia. There are issues that are reported on, and we can use those situations to then eliminate those risk factors and eliminate those potential hazards that may have caused that situation. So again, I think when we look at all these different resources that are available to us, it's a combination of all of them that we can use to improve our anesthetic practice. It's important that we also know that they all have their own risks that come along with them, their own downfalls, and that we are not relying too heavily on one versus another, but that we use these in an effective way together to provide great care for our patients.
And I just want to add to the farther out people are from school, it seems, at least in my experience and the growing trend that I've seen, is that once anesthesia providers graduate and the further away they get from school, the less likely they are to keep up to date with the ever-growing and ever-changing technology, interventions, improvement, knowledge that we have related to our care. And so it's so important not only to look at these safety standards to provide risk management to these patients, to understand how we're increasing safety to them, but also just updated and new technology, new ways of doing things that are approved and part of protocols, etc. And the further we get out of school, it seems to be that people don't keep track of these things as much in terms of the up-to-date knowledge. And then the next generation of people that are graduating, they, in their education, get this updated technology, updated information as part of their training. And I've seen that a lot for a tangible example in terms of ultrasound. As Tanner and I have recently graduated in the last couple of years, we had ultrasound training as part of our education. And there are a lot of CRNAs that I work with that are unfamiliar and just less comfortable using ultrasound in their practice because they didn't have the official education on that. And that's just a tangible example, but there are things that we should constantly be seeking and looking for. What are the different things in our field that are being updated and being provided to us? And the AANA and the ASA and all the guidelines that they publish, all the information that they publish, et cetera, are great resources to utilize to make sure that we're up to date with all this information. And again, the reason that we're doing all of this in the last 3 talks altogether, in summary, is to make sure that we're providing the best anesthetic and care that we can to our patients, that we're limiting the amount of risk that we have to them, and that we're enhancing safety to them, but then also that we're able to meet their needs in terms of pain management, anesthetic management, et cetera. So hopefully this has been beneficial to you. Hopefully you've learned a lot from this and that you can take this into your practice and you can utilize these resources to help you grow in your practice and grow in your knowledge of what are the different protocols that are out there. Are there things that I need to be paying more attention to, things that have been updated since I've last looked at things, et cetera. And just having these thoughts in your head for when situations arise that you're able to maximize the amount of care that you're able to do to these patients.